Yeah. Thank you everyone for joining. I think we have put this on the screen as well. This session will be recorded and we will post the link on our discussion forum on ISOP as well. Whoever couldn't attend would be able to attend, would be able to hear the recording. If you have any concerns, please feel free to drop the session. I would like to introduce our speakers for the immunogenicity data. We have two speakers, David Radtke and Jane Kang. David Radtke, David studied molecular genetics and biomedical engineering at Purdue University. After graduation, he worked for several years in alcoholism and liver disease research at Indiana University Medical Center, after which he joined Eli Lilly and company's global PKPD group. He has been with Lilly 27 years, spending majority of the time as a pharmacokinetic scientist and pharmacometrician, with the brief side of forays into computer system development, quality, and validation. David is also a member of the Control Terminology Board for the PP and PC SDTM domains, as well as a participating member of the NCA and PubPK initiatives for ADAM. Our other speaker, Jane Kang. Jane received her MS in computer science in Towson University in 2000. And she has MD in biomedical engineering from Shanghai Medical College in 1992. She joined Merck and Company Inc. BART's scientific programming team in 2004. In 17 years with Merck, she gained extensive programming experience in safety, efficacy, and immunogenicity analysis in multiple therapeutic studies and has been involved in multiple submissions in both analysis and reporting and the PKPD programming. In the recent 6 years, Jane has been focusing to support pharmacometricians in creation of analysis data sets and tables, listings, figures for PKPD analysis and immunogenicity analysis in oncology studies. So I would like to invite Dave and Jane to start our session. Thank you.
And thank you. Just real briefly, as a matter of housekeeping, the PKPD programming group, which is sponsoring this, is more focused on programming and collecting data for data sets for pharmacometric analysis, and not as focused on the actual process of pharmacometrics analysis or pharmacokinetic analysis. So the focus of this talk is going to be more on the data itself, the data flow, how we're putting data sets together, and then hopefully I'll be able to try to address maybe some of the whys. Why would we ask for things to be laid out in a certain way? Why would we ask for things to be derived in a certain way, and how they might be used in analysis and effect analysis? I'm also going to give you a brief background on immunogenetics, just so everybody's on the same page. But the disclaimer is that I'm not an immunologist, and so take everything I say with a grain of salt. I've tried to be as accurate as possible, but it is certainly not an in-depth review of immunology by any means. Again, it's more to give everybody a background of why we're collecting certain things and where those might actually come from. So with that, I'll get started. Oh, and by the way, we will stop the recording of the session once we get to the end of the presentation, when we're taking any questions or having any final discussion. So hopefully if there's a concern about speaking up during the session, we'll stop recording and we'll give everybody an opportunity to have some discussion and ask some questions. Okay, so I'm going to use this slide that gives an overall data flow as a way of transitioning between sort of the sections that we're going to be talking about. Initially, this first part is going to be discussing raw data. Then we'll move along to the actual compilation of that raw data into primary data storage units such as SDTM files, and then how they may be then translated into various types of analysis data sets, whether that's an atom file, whether that's a custom file, or whether that's a data set that the pharmacokineticists or pharmacometricians might be a little bit more accustomed to as like a non-mem style data set where you have one record per observation. And then finally, the last part of the talk will be talking about the derivations of that. What are we going to do with the data once we have it? What types of things do we do to actually examine the data and then interpret what the effect might be? So this slide will reoccur in slightly different formats throughout the presentation, just so you can kind of see where we are in the process and hopefully kind of tee up each section as we go through and discuss. So initially, I want to give you a background of immunogenetics or immunogenicity and immunology as it relates to effects on drug molecules. So due to size, oftentimes large molecule therapeutics can be mistaken by the body as a foreign invader. This is not something I created. It doesn't belong here, therefore we need to get rid of it. And this obviously elicits a response from the immune system. Some of the drug types that fall into this category include antibodies, cytokines, growth factors, hormones, insulins, large molecules, again, that may be used in therapeutics, but again, the body doesn't recognize it as coming from itself. And it could be that there's just slight modifications to that. So like in the case for antibodies, for instance, antibodies that are monoclonal antibodies that are raised in animals have a much higher immunogenicity rate than ones that are monoclonal based on human cells. So it's those types of things that elicit that response within the body, and that can have a negative effect on various aspects of drug disposition and efficacy. So the antibody development can be triggered by the amount of dose. Sometimes if we dose at a lower amount, sometimes that we can prevent an antibody response from being created than if we dose at a higher amount. Sometimes it's the lower amount of dosing that initiates the response. So a lot of these can go both ways in their driving of whether or not we elicit a immunogenic response. So frequency of dosing also can trigger that, the duration of therapy. So short-term therapy versus very long chronic therapy. And it's one of the concerns we have, especially with the disease-modifying molecules for things like rheumatoid arthritis or for things like psoriasis or Crohn's disease. A lot of these drugs, these patients may be on for potentially the rest of their life. And so developing antidrug antibodies to this may mean that patient, that drug fails to maintain efficacy for that patient over time. The size of the molecule obviously also plays a factor in it, and the type of the molecule, how close it is to something that might occur naturally or something that might be developed by the body. Safety and efficacy, and of course, PKPD can be affected by the development of these antidrug antibodies. But sometimes we develop antidrug antibodies and they don't really have an effect on the actual efficacy or the mode of action. When they do, we use a term called neutralizing. So the antidrug antibodies that are created could be neutralizing antibodies. And so again, we're throwing out a lot of terms here, but I'm trying to get everybody on the same page. So if we're talking about neutralizing antibodies, these are ones that actually inhibit the efficacy. ADA alone may have altering effects on half-life, so if it's a non-neutralizing antibody, I may be changing what would typically be considered kinetic parameters, clearance and half-life. If it's a neutralizing antibody, then I may be impacting things like efficacy, whether or not my drug can affect its target. And then that may have an effect on therapy immediately or over time. It also may have an effect on safety. If for some reason bonding of antibodies means that the molecules are being retained in the body instead of cleared from the body. All of those things can have an effect. And that's part of what we evaluate when we collect this information and look for the effect of antibodies and the potential neutralizing effect that they might have. So just briefly, when we talk about an antibody, it's this typical characterization that most people are familiar with. There are the concept of light chains and heavy chains, and this if we're going to abstract and say sort of this Y shape, the top part of the Y is the antigen binding site, and that's often most associated with the light chains. But then you have these heavy chains, and you also have a constant region. When we develop a monoclonal antibody in animals, it's that constant region that the body may be reacting to more so than the antigen binding site. When we develop them in humans, oftentimes it's more the antigen binding site that might trigger the response. The typical path or the typical mode of action would be that we have a therapeutic protein that's fairly complex. The body recognizes it as not being natural to its state, therefore a foreign object in it, and you have antigen presenting cells that will then encapsulate and attack these proteins. From those we get T cells, and the T cells progress from a naive T cell, which is an undifferentiated, to an activated one. That then progresses into B cells. Once the B cells become activated, there's actually a piece here that I don't display where there's a split. And so some of those B cells become memory B cells, go into the bone marrow, and some of them become essentially antibody factories. They're released into the plasma. That circulating B cell that's been activated then produces antibodies that then bind to whatever foreign object it is that the body identifies as not belonging there, in this case, our therapeutic protein. Now, it could be that our therapeutic protein is some bioengineered protein. It could be that it's another antibody. So as I mentioned before, some of the early disease-modifying drugs that we have out on the market were raised in animals, and oftentimes those have a fairly decent immunogenic response. And in those cases, then it's that recognition that this particular antibody did not come from a human source that may be causing some of the interaction. And then neutralizing versus non-neutralizing antibodies. A non-neutralizing antibody, the binding site's actually binding probably to that the constant region, right? So it's not affecting the part of the antibody that is actually recognizing the structure and binding to the structure. So the antigen specific site, it's the non-specific site that it's binding to. And the reason I say that it can affect clearance and half-life, once you have antibodies binding to a molecule and they start to cluster together, that's when the white blood cells come in and take out those molecules, encapsulate them, and then remove them. So you can have clearance affected. You can have the removal of measured drug in the body because of this binding. And so what you're seeing, apparently, is you're seeing the concentrations go down over time. It also could be that the binding holds those molecules in suspension longer than intended, and they may have an effect in other ways. So you might actually see concentrations go up. If it's a neutralizing antibody, then the antibodies created by the body against this foreign molecule are attacking the actual binding site or the site of interaction. And when that happens, it can do both. So it can not only stop that molecule from working or affecting the site that we want it to affect, but it also then can cluster and sequester molecules and keep them from taking their normal course within the body. So those are the two concepts, neutralizing and non-neutralizing. From that, I want to go over a basic flow. So we have patient samples that are taken, blood samples, just like we would take a concentration sample. That blood sample goes through and it sometimes can be even the same sample that we take for drug concentrations. We'll run through a anti-drug antibody screen. If we get, and usually that's verified more than once, but if we get a signal that's below a cut point, so some small amount or a non-detectable amount, then we declare it to be non-detected. If we get a signal, we test again. And if that signal happens to be above some cut point, some declared value, then we confirm it to be an anti-drug antibody. So we get a flag, essentially a positive negative flag of this is now positive. It's confirmed that we have an anti-drug antibody. Then that is passed on to a titration step where we actually try to assess how much antibody is there, and we establish a titer. So now we have detected anti-drug antibodies with a titer, and then we do an assessment of neutralizing or non-neutralizing. Does this actually affect the mode of action of the drug? And if it's below a cut point, we declare it to be non-neutralizing if it's above neutralizing. So then what we collect from all this is we tend to collect flag type information, or what as a kineticist or pharmacometrician I would consider a flag, not necessarily always what CDISC considers a flag in terms of yes or no. But in this case, we'll get, do we have anti-drug antibodies? Yes or no, positive or negative. Do we have a titer? That titer, unfortunately, is not usually a linear number that we can say 1 to 1,000. It's usually presented as a dilution. So it can be both, depending on how your company sets this up. But typically what I've seen is this is a dilution factor. And so it's not just a number, a sequential number from 0 to infinity. It's some dilution factor, it's some value. And generally those values have steps. So I wouldn't necessarily consider the titer to be a continuous variable either. It can be modeled as a continuous variable, but I have not done so. Generally, we try to categorize those differently, and we'll get to that discussion later. And then finally, you might get a flag of neutralizing or non-neutralizing. Now, all of these data were, when they first started appearing on the scene and we were doing these assessments, we were putting this data in the LB domain. And now there's a specific domain created for that, the IS domain. And again, your company may have specific other things that it does with this IS domain, in addition to these rough characterizations of the types of data that are presented. They may have some derivations of these data. So for instance, there are other factors, such things as treatment emergence, and that might be declared in this IS domain, or it might be reserved for assessment in an ATOM domain later on, or an ATOM file later on. So essentially there's, with these additional characterizations, there's a determination if the anti-drug antibody is pre-existing. Sometimes, even though the patient may have never been exposed to our particular target molecule, our drug, at all, they may have some non-specific antibodies that bind to that. And so in the case of the example therapeutic antibody that I started with, this might be due to non-specific binding to the consonant region, that sort of stem of the Y, if you will. And we have to assess, is this real? Do we see this non-specific binding due to assay sensitivity or some other factor? And so we may declare that if there is a positive titer, even before we've given drug. So generally when we do an ADA assessment, we do a baseline sample. And if it's there, if we measure something, then we kind of have to determine, okay, is some low level amount we consider assay sensitivity or an unspecified binding that we don't declare to be created due to the presence of the drug. And then some companies use the term to assess this increase from this pre-existing baseline as boosted or enhanced by therapy. So yes, you had an initial reaction, but we're not going to declare that initial reaction to truly be a body reaction to the drug. But once we started administering the drug, boy, we saw the titer measurement of this anti-drug antibody that you already had on board. We see binding go way up. And when we see that, we can declare this to be boosted or enhanced by therapy. We can all, at least I've also heard it to be declared as treatment emergent. Criteria obviously would be establish a priori to determine the different scales of titer, to declare a positive or just, sort of the presence, we have an antibody there, versus treatment emergent versus, some sort of effect of this is serious or non-serious. And so there are lots of different assessments or flags that can be used. And that then creates a lot of confusion as to how do we assess this? How do we assess its effect on PK? And then finally, they may have additional characteristics such as persistent or transient. Sometimes we get anti-drug antibodies developed initially when we first start administering a drug, but once we go into constant or continuous administration, they don't ever increase beyond a baseline value, or they decrease to a non-detectable level. That would be considered a transient type of response. Persistent response would be we start administering the drug. Within a few doses of the drug, we see the development of anti-drug antibodies. And then we see that amount go up over time or continue to stay at a plateau level over time. And so we might then categorize that as persistent. So that gives you a background of the raw data that's collected. Jane's going to take over now and talk about how then that data is distilled through what we consider to be source data sets or SDTM data, and then further derived out into our analysis data sets. And then I will rejoin at the end and talk about sort of the whys and why we would ask for things to be coded a certain way, how they might affect our analysis, and what we might do with that. So with that, I'm going to turn things over to Jane.
Yeah, thank you, Dave. Can everyone hear me?
Yes, we can hear you fine.
Good. So in Dave's talk, we understood the mechanism and the different aspect of an immune response to the target drug and its potential impact to PK, PD, drug safety, and efficacy. Now, I would like to illustrate with real-world example of how those collected immunogenicity measurements are handled in raw SDTM data, ADA analysis dataset, and other PK analysis dataset. Next slide, please. Yeah, so we will talk about what will be included in the analysis dataset, and contents can be varied, and examples in the SDTM, ADA analysis, and the PK dataset with the ADA variables. Next slide, please. So first of all, let's start with the overview of what are usually included in the ADA analysis dataset. Immunogenicity analysis dataset usually contain sample level testing results, sample level evaluation, subject level evaluation, relative time variables, and some other flag variables to assist define ADA status, or other study-specific covariates and the core variables from ADSL. At sample level, in line with a multi-tier ADA evaluation process as described in the data flow in David's slides, raw testing results includes binding ADA from tier 1, like screening result, and title 2, confirmatory testing result. Title 3, magnitude of ADA, such as like a titration, or in some company could be also testing for signal to noise for confirmed positive ADA. And NAb, like neutralization ADA for confirmed positive ADA as well. At sample level, we also include PK concentration measurement at the time of ADA sampling. So we can compare with the DTL, the drug tolerance level, to determine whether this ADA sample results is reliable or conclusive. At the end, sample level evaluation is summarized upon the raw testing result and the conditions described above. At subject level, ADA status is summarized and determined at the different aspects. So as David also described previously, we include the pre and post-treatment ADA status to find out the change from pre to post. If before treatment and after treatment are both positive, we would like to check the change of ADA magnitude to understand whether the treatment affect the ADA response. And in the definition of subject level status, all samples are considered in order to understand the BAB, the binding ADA, and the neutralizing ADA results. In addition, timing of immune response are included in to analyze the PK effect from ADA, so as to the impact to safety and efficacy, especially when there is high instance of ADA positive response. This includes relative time to the dosing time, like a relative time since first dose, since last recent dose, or to the referenced dose are also expected. Other flag variables are included to indicate whether this subject is evaluable for ADA analysis should be included or excluded? Does the APK concentration exceed the DTL? Which sample is the last valid ADA sample? Is the ADA positive, persistent, or transient? Is this a positive ADA treatment emergent, induced, or boosted, or unaffected? Depending on the study's specific need and the instance rate of immunoresponse to the study drug, there are various questions to be answered. The analysis dataset is to be created in a way for modeling analysis to answer those questions. Often we see to include ADA core variables for completeness for submission, and additional covariates are needed for modeling analysis. Next slide, please. We have discussed many variables in the overview, but in reality, the variables actually included in the dataset can vary depending on company standards, practices, and historical approach in the company, in different company. So dataset variables, dataset structure can be quite different because of that. We would like to summarize the difference as shown on these slides. So first of all, it varies depending on the SDTM dataset. Firstly, what are in SDTM dataset, in the IS dataset can be different. In some company, SDTM dataset only include the raw ADA measurement. Other companies may have a sample level evaluation and even subject level evaluation in the SDTM dataset. Secondly, SDTM dataset structure can also be different as well. It can have a one record per sample, and then multiple tier measurements are presented in the different variables. So we call it like in horizontal structure. Or SDTM data can also present in the vertical structure with one record to represent each tier of ADA measurement. We call it the vertical structure, and then we can also see the mixture of those two different structure. And obviously, the analysis dataset also depending on the analysis need. On one hand, we see ADA dataset contains additional PK records. It helps to build ADA effect to the PK. On the other hand, we also can see people include the ADA variables in the population PK dataset in order to build the population model. As we discussed earlier, it really depends on the company historical approach. In most cases, different presenting in both SDTM data and the analysis data set are due to company standards and historical approach. Immunogenicity analysis data set can vary in either structure wise or variable wise. In next few slides, I would like to walk you through the data set examples we collected from different companies. Next slide, please. So this slide shows a SDTM-IS dataset which contains both sample level evaluation and the subject level evaluation at each time point. In this example, raw testing data, tier 1, tier 2 are not included. And at each time point, subject has one record for sample ADA status and the other record for subject level ADA status. When sample is positive, subject has another record for titration measurement. Next slide, please. This slide shows two examples. In these two examples, raw assay results are included in the IS dataset. The difference are the top one contains one record for binding ADA test, the other for neutralizing ADA test if it's available. The confirmatory result and the titration result are presented as a subcode variables. It can be considered as a wide horizontal structure, like a one record per sample. The bottom one presents raw raw assay results as one record per assay test. Variable ISSCAT is used as a qualifier for each test. It is called narrow, we can call it as a narrow vertical structure, like one record per test. And next slide, please. So this one, now let's take a look the analysis data sets. This example shows this is okay, hold on. This is the slides we just talked about. The variable shows in the subcode. You see the confirmatory and titer show as a subcode of IS dataset. And the later one, you see the raw data are presented in the vertical structure. Next slide, please. Yeah, this one is this slide is talk about analysis data set. The example shows one record per analysis parameter per subject per time point. It is a data set in vertical structure, so-called BDS Adam compliant structure. Parameter CD and parameter PARM are used as qualified variables. For each subject at each time point, we can use these two variables to identify different analysis data points. And show in the light blue shade rows, those are record raw collected data. And green shaded rows are sample level evaluation. And then show in the pink shaded rows are subject level summaries, which include subject level status and also the various flags needed for this study analysis. Next slide, please. So this slide shows the analysis data set in horizontal structure, one record per sample. Each raw assay test, screening, confirmatory, and the titer result are presenting in variable SCR, RSLT, and CNR, RSLT, and the titer. Sample level evaluation presented in variable ADA sample, included in the pink dashed rectangle are those variables for subject level summary, like a baseline titer, maximum titer for the subject, neutralizing result, subject level, neutralizing ADA result at subject level, and ADA binding ADA subject level result, and the combined ADA result at the subject level. The screenshot at the bottom shows the additional shows the example additional PK sample can be easily added in the horizontal structure dataset. In this case, an indicator can be used to differentiate the ADA record with PK sample and also additional PK samples. It would be easier for a modeler to analyze the ADA PK effect, for example, to create PK profiles by different ADA categories. Next slide, please. So besides of the ADA data set with pure ADA data, we often see combined ADA variables with PopPK data set. Here is an example of a PopPK data set with ADA subject status variables. So it's as you can see, it's a ADAS is a subject level ADA status. Next slide, please. This is an example of a PopPK dataset with ADA subject level status variable, ADA list, and then sample level variable, titer, and ADA. Next slide, please. This is another example with ADA subject level variable and the sample level ADA status variables. So as you can see from all these real world examples, immunogenicity data can be presented quite differently in different companies, such as the different variable name, record layouts, and the flexible structures. No matter how data are presented, it can all serve the same goal to analyze the immune response to the drug and its impact in drug development. So hope all these examples are helpful for you, and we would like to hear from you at the end for the more practice done at your site as well. Thank you. Back to Dave. Back to you, Dave.
Thank you, Jane. So we've talked about the raw data that's collected. We've talked about how that data might be made available to us in terms of our source information that we would then program. And as a kineticist, then there's ways that I want to try to have that data coded in my analysis data sets for the specific type of analysis that I'm doing. And Jane had mentioned that the examples that she provided were from multiple companies. So not just her specific examples, but ones from several of the representatives in our group. And there was a lot of differentiation between companies. But even my experience is that there's a lot of differentiation between pharmacometricians or pharmacokineticists in the way that they prefer their data to be coded. So even though we try to strive for some similarities, each of us have our own little quirks in how we want to approach coding and how we want things coded. So you may be asked to reorganize that data from source into different ways of including it in the data set, whether it's as a yes/no flag or some other type of categorical variable, or possibly a continuous variable, although not often with this type of data. So as I mentioned, we might take this information and we would code it as a flag, right? So we would say, yes, there is a presence of anti-drug antibody. No, there's not the presence of anti-drug antibody. We might pull information from further ADAM data sets like ADSL, like an ADIS, where they might then apply some criteria to say that this patient has treatment emergent anti-drug antibodies, which we might not have from the source. So let's say, for instance, our source SDTM really only presented raw data. So we might be pulling some of those positive, negative type evaluations from the raw data and include those as flags, as true flags in the sense of they have a binary value of 0 or 1. We might also potentially look at the titers and represent the titer values as categories. So a titer of nothing to 1 to 1,000 dilution might be coded as a 1. Something from 1,000 dilution to 10,000 dilution might be coded as a 2. Because these titers are often stepwise, as I mentioned before, they don't lend themselves to be a continuous variable. So actually using the titer value itself as a source of information that I might code with. So I most likely will have that categorized. And then oftentimes, because of the way that we're looking at data, we then have that data further derived. So we'll take that information from the raw, we'll turn it into subject level evaluations of whether or not they're treatment emergent, whether or not it's persistent or transient. And those types of information may then also be turned into flags that we populate in our analysis data sets. So the other considerations we might have for these is that because of anti-drug antibody, it may force us to recode or handle our samples, our drug concentration measurements that were previously measured as below limit of quantitation. So oftentimes companies will have a rule that will say, hey, if there are only a handful of samples that are below the limit of quantitation, we're just going to treat those as missing. We're going to ignore those. Or they have a threshold value that if over 20% of them are BQL, then we'll treat them as some baseline value, whether that's just a number that's at BQL or just a number that's half BQL or some other number that we assign to that value. We may need to reassess how we handle those because of ADA, right? Our assessments of antidrug antibody, treatment emergent antidrug antibody, and neutralizing antidrug antibody may drive how we assess samples that are measured as below the limit of quantitation or unquantifiable, especially if there's a large number of them in correlation to a flag status of positive antidrug antibody. Our covariate imputation may be handled differently. So it may be appropriate to say that once a person is positive, we're going to treat them as positive for the rest of the analysis, kind of a cascading or mortality type analysis. Yes, they hit a flag, we're going to treat them as that way throughout the rest of the study. Or we may only be able to evaluate that for that period because we see that these effects are transient. Or it might be appropriate to say we need to carry information backwards. The antidrug antibody may also have an effect on the way we code other covariates as well. So just keep in mind that there might be some unusual requests to recode or to reevaluate how things fit together in an analysis data set based on the perceived interaction between the antidrug antibodies and the drug that we're examining. A lot of times when we look at the impact scenarios that can happen, at least from a kinetic standpoint. So this is my direct impact on how I see antidrug antibodies. And I'm going to separate this a little bit from efficacy and look more at the effects on kinetics itself. But if the clearance, if we see that the clearance level of the drug is approximately equal to the clearance level of this antidrug antibody complex that's been created, we might actually see decreased drug concentration over time. So what we'll see is those patients who are identified or flagged as treatment emergent or antidrug antibody positive or neutralizing, it could be any one of the three. If the values are relatively the same, then we say there's no change, right? If this complex with the drug is much greater than, or if the complex of the antibody and the drug is much smaller, that's the second line here, than the actual drug itself, then that clearance of the complex might actually not have an effect, or it might have an increased effect on drug concentration time profile. So again, we might see that those subjects that we flag as being affected by antidrug antibody actually have higher concentrations that we measure, especially for a period of time. And then finally, if the clearance of the drug winds up being much less than the clearance of this complex of bound antibodies and drug together, then we'll actually see decreased drug concentration, and we'll see measurements that decrease over time, or measurements that are lower than would be expected. And I'll try to show that visually because this table doesn't describe that as well as I'd like. Here's an example. This is just a very rough characterization, both of intense sampling or dense sampling data, something we might see in an early phase study, and sparse sampling data that we might see in a population-based study. And so all I've done here is I've basically said, okay, I'm going to make up a mean curve, and then I'm going to suggest what that effect might be theoretically on if I had presence of antidrug antibodies and how they might affect those concentrations. So if I have antidrug antibody that's binding my drug, complexing it, keeping it from binding to the site or affecting the site, I might actually increase drug in systemic circulation. And that changes my distribution and binding. And so what you see is the blue curve, or the blue data off to the right, where the samples we measure are actually greater. Now you notice that the peak's not much greater, but what we would consider to be the distribution of the sample, that's between 0 and 24 hours, and the elimination of that sample between 24 and 72, those values are increased, they're higher. And it might actually change the amount of time that the drug circulates within the body. If we have an opposite effect, so if the binding actually removes that drug from systemic circulation faster because of white blood cell activity and destruction of the cell, or a destruction of the drug, I should say, then we might see a suppression of the drug concentration. And again, doesn't usually affect peak that much, but what we'll see is in the distributional and elimination phase a much greater effect. And so you'll start to measure concentrations that are lower than expected. So both of those things can happen depending on the mode of action and depending on what's there. That was always something that was throwing me off in the beginning when I first started looking at antidrug antibodies. My expectation was always that the concentration would be lower, but sometimes that's not the case. And this is more of a real world example of what we might see in terms of characterization. And this could have a number of interpretations. So I'm not going to get too much into, well, what does this say? Because without knowing 100% the entire background of the study and how the data were collected and what this actually might mean, it's hard to interpret because you could actually look at it both ways. For instance, the symbols that are coded in red, they're flagged as treatment emergent, neutralizing antibody positive, right? So we have an antibody that's created because of the presence of drug. We've determined that. The effect on that antibody is that it's a neutralizing antibody. And so what we're seeing is a decrease in concentration. So presumably the complex of antibody and drug are causing that drug to be removed from measurement or removed from the ability to measure that in systemic circulation. Now we could interpret this to be, okay, that patient dropped off study because obviously they weren't receiving a high enough therapeutic dose to be effective. And so maybe the fact that we only have samples out to 84 hours is representative of the fact that we lost that patient in this trial. It also could be reflective, since I'm not indicated these samples by an individual patient, it could be reflective of a transient type of response. So we have an early on antibody response, but later on we don't see these. Or the neutralizing effect becomes negative. So maybe some of those yellow circles, which represent positive antibodies, but a negative antidrug antibody effect, maybe some of those belong to the same subject, and we see that effect later on. So initially, one might look at this and say, well, this is pretty much saying that, yeah, there might be antidrug antibodies that are created, but they're not having much effect on the PK. And so maybe in this case, we don't care, or we're not too worried about this, at least over the course of therapy that we're showing here. But this could be of concern later on, if, for instance, this were a chronically administered drug, and the expectation was this patient might be taking this for the rest of their life, in which case 2 or 3 years down the road, those neutralizing antibodies might come back to have an effect, might reduce the concentration, thus impacting efficacy, thus impacting potentially even safety. As I mentioned before, if the bonding of the antibody means that the drug stays in systemic circulation longer, and we're dosing the drug on a frequent basis, we might actually be building up concentration of that drug in the system to a point where it then reaches a toxicity threshold. So this could have effects on safety as well as efficacy. There are other types of ways to look at this data graphically. Certainly this is a pharmacokineticist viewpoint at it. If I'm looking at this from a clinician or a statistician standpoint, I might be looking at things like a Kaplan-Meier curve to look at degradation of effect over time. I might be looking at response and effect to look for a relationship to, yes, when there's neutralizing antibodies, we have a blunt of effect, or these patients no longer experience efficacy, that type of thing. But when we do these evaluations, we're predominantly looking at how it might affect our population analysis, or at least I'm looking at how it might affect my population analysis from a standpoint of changes in distribution or elimination of the drug of evaluation. So from a coding needs standpoint, we would code these most likely as covariates in a population PK data set. That's not to say that they couldn't be coded as a dependent variable, but most likely these are going to be coded as a covariate. They could be used to evaluate a state, positive or negative, or a classification, treatment emergent, non-treatment emergent, persistent or transient, neutralizing or not neutralizing. And we would look at those on the kinetic features of a model. So we would use these to assess the difference in clearance or volume, for instance, when neutralizing status or some other status of effect is positive. So is there a difference in the way that I evaluate the way the drug is cleared, in other words, how fast the body gets rid of it, or the presence of the drug, the exposure to the drug, and that's affecting the volume that I measure? How might that antidrug antibody or neutralizing antibody status affect that? So I would then want that coded as a covariate. I could also code these as dependent variables. So in other words, have the values for my antibodies be in the same column as the concentrations that I'm measuring. And then I might look at this mechanistically, where I could say that a particular compartment, as that compartment has a flag or a value change of positive to negative, then that has a shift or a change on the measurement of the drug within other compartments. So I might be looking at a rate of transference, I might be looking at a rate of conversion, and all those things might affect my model that way. So yes, there is a reason to code these as a dependent variable, but again, I'll state most often we're going to look at these from a covariate standpoint. So what effect does this antidrug antibody status have on my on the kinetics of my drug, the characteristics of my drug? Okay. And then I guess with that, I'm going to come to the end of the recorded part of the session. So if we can stop the recording, I wanted to have a brief discussion, and I will tee up each of the questions and then ask if anybody has any comments or thoughts on that. So if we want to go ahead and stop the recording.